Hi everyone, welcome to the PsySOM revision lectures. My name is Jonathan and today I'll be presenting on mood disorders. On this slide, I have put my email there, so feel free to email me if you have any questions or feel like I missed anything that you want some more info on these slides. So yeah, before we get started, this is just the overview from the most recent matrix I could find. If there are any conditions that I may have missed, I don't know whether or not they've updated it within the year that followed this specific matrix, but yeah. So this will be quite a short lecture just because there are only two R1 conditions that will be covered here, and the rest are R3, which from my experience will only pop up as multi-choice options and are usually quite buzzwordy. So yeah. So firstly, what is mood? So mood is a subjective description of one's eternal state of being, and it's one part of the umbrella term that is emotion in psychiatry. The other part is affect, which is the external display of one's mood. So if you just think about it, mood is how someone describes how they're feeling. So if I told you that I'm sad, then that's my mood. However, if I'm quite bubbly and I'm quite jovial, then my affect would not be congruent with my mood, if that makes sense. So affect is something that you can describe of someone else without them really saying anything, but you can't really assess mood without them telling you straight up. So a normal person would have wide ranges of mood, and this is quite a good indicator of just normal functioning. And fluctuations are also normal. Mood disorders in particular are when a patient's mood is not controllable and it's causing impairment to their daily life. And this is a very common disorder. So yeah, firstly starting with bipolar and manic disorders. So defining mania, according to the DSM criteria, I've kind of broken it down a little bit. It's a big block of text when you actually look at the criteria, but essentially it's just if a patient has an elevated or irritable mood and increased activity for more than 7 days. Um, and if we're breaking that down into more specific symptoms, it's three or more of the following symptoms if their mood is described as elevated, or if they describe it as irritable, it's four or more. So this is quite a good mnemonic to learn just for OSCEs and for the exam as well. It's dig fast, and this is based off the actual DSM criteria. So let's just go through them really quickly. The first one is distractibility. So the attention is too easily drawn to unimportant or irrelevant external stimuli. And you'll see this quite easily in interviews in your OSCE. So if the patient keeps standing up, changing positions, walking around, pacing, that kind of thing, um, that could be called distractibility. Impulsivity, so excessive involvement in activities that have the potential for painful consequences, so gambling, risky investments. You can also see unsafe sexual practices, that kind of thing as well. But in the classic example that you'll see in exams and OSCEs, it's when they start spending like all their money on something that doesn't make any sense. The third one is grandiosity, which is quite self-explanatory. They feel like they're on top of the world. They are more talented and more great than anyone that's ever existed. And you can categorize this quite easily, because if they were to say that they're the best like baker in the world, there is like a spectrum for that. So you'll see that quite often in real psychiatric interviews as well. Flight of ideas, so this is an important one. So the continuous flow of accelerated speech with abrupt changes from topic to topic, and you'll find that they're quite hard to interrupt as well. So activity increase or psychomotor agitation, and then sleep deficit. So feeling rested after a little sleep, they can sleep 3 hours and still be completely fine. And talkative, so more than usual or pressure keep talking. This might be better assessed with a collateral history, because some people are just talkative. And the third criteria is severe functional impairment requiring hospitalization and are not due to any substances that you can gauge from the history. So in terms of a mental state exam, the appearance and behavior, they're very energetic, very excited, talkative, and frequently hyperactive. They're possibly psychotic, disorganized, and aggressive. So psychosis is also another defining feature between type 1 and type 2 bipolar affective disorder, but we'll talk about that a little bit later. They'll also have intense eye contact and psychomotor agitation. So pressured speech is also a big sign of mania. It's fast, difficult, or impossible to interrupt, and like increased quantity, they just keep talking and um, you don't really know where any of it's coming from. In terms of emotion, so classically they have a euphoric mood, and this is described as elated or elevated or even expansive. It's labile, which means that it changes quite quickly, so they can jump from one emotion to the other really quickly. And an intense affect. So they have high emotional intensity and responsiveness to things around them. So if they were really, really happy and you told them something that would make them sad, it jumps really quickly and really intensely. In terms of thought, so thought stream, you'll see flight of ideas. So that's what I talked about earlier, continuous flow of accelerated speech. Thought form, there'll be evidence of formal thought disorders, but it's not diagnostic. So you can see tangentiality, circumstantiality, all of that. They'll just talk really quickly and you might be able to make some sense of it and pathologize it, but it's not quite a diagnostic criteria. In terms of content, so self-confidence and grandiosity, so what I was talking about before with increased confidence in their skills and abilities, and they're easily distracted. So just talking about different things. In terms of perception, so delusions are present in 75% of patients, and that's usually grandiose delusions, and 51% will have hallucinations, whether that be visual or auditory. Auditory. In terms of insight and judgment, so they'll have impaired judgment, which is a hallmark sign, and this is where you'll find the excessive spending, unsafe sexual practices, just bad decision making in general, and they often have little insight into why they're doing it unless they've been, from my experience, unless they've been diagnosed for a really, really long time. But once they're in the acute stage of mania, they really don't think that anything's wrong. So just an overview of the bipolar disorders that are covered in your matrix. So the definition of a bipolar disorder is a mood disorder that is characterized by prolonged periods of elevated mood and or depressive episodes. So you can see here, I've drawn a little mood diagram, and you have elevated mood at the top and low mood at the bottom. And we can say that right at the top here is euphoria, and a low mood would be like a severe depressive episode. So bipolar affective disorder type 1 is categorized by the like mania and plus or minus episodes of depression. So the diagnostic criteria, which we'll talk about a little bit later, doesn't necessarily require a major depressive episode. Um, However, type 2, they're categorized by hypomania. So they're not quite at the top where you'll describe them as manic, but it's hypomanic, and we'll also talk about that a little bit later. And the diagnostic criteria for type 2 does include depressive episodes. So it's hypomania plus major depressive episodes. And then cyclothymia is very rapid. I wouldn't say rapid actually, because in reality it's within the course of like weeks or months. But it's just like the relatively quick changes in mood from hypomania to mild depression, not necessarily a major depressive episode. And it's more of a chronic condition. We'll also talk about that later on. So firstly, bipolar affective disorder type 1. In terms of the epidemiology, males and females are equally affected. The lifetime prevalence is 1%, and they have a trimodal distribution pattern. So classically on exams, I think that these will usually be diagnosed in the late teens. However, there are also peaks during the mid-20s and early 40s. Super, super high suicide risk. So something to keep in mind when you're giving your OSCE management plan. So, in terms of risk factors, an anxiety disorder in childhood is seen in a lot of people diagnosed with bipolar affective disorder. But another one is also genetic. So, if they have a relative with a mood disorder or a bipolar disorder, they're at a much higher risk. Depressive episodes usually precede manic episodes, and risk factors for poor prognosis include a dual diagnosis with substance abuse, or comorbid anxiety, rapid cycling in mania and depression, whether or not they're male. So males are at a higher risk for a poor prognosis, and mixed episodes or features will also indicate poor prognosis. In terms of investigation, so bedside, you do a UDS or urine drug screen, just to see whether or not this manic presentation is substance related, and also an ECG. In terms of pathology, so you want to do an FB to rule out anemia as a cause for depression, ESR, rule out underlying disease such as a lupus or infection, blood sugar levels. This one is because a lot of the psychiatric medications that you use for patients will have a lot of metabolic side effects. So usually as a baseline, I think you'll do a blood sugar level and fasting lipids just to get a baseline of their metabolic function. Electrolytes, so sodium's associated with depression and also your kidney function. EGFR and creatinine for kidney function. Lithium is a big is very nephrotoxic. So whether or not you're going to put them on lithium, we don't know, but it's usually good to get a baseline anyway. And then TSH, so organic disorders, hyperthyroidism can manifest in depressive and anxious presentations. In terms of imaging, so an MRI can be ordered if there are negative neurological findings or an abrupt and late age of onset. This is usually to rule out stroke, brain injuries, or tumors as a cause for the presentation. So in terms of the acute management of mania, firstly, when you're in ED, so de-escalate by using a calm room, verbal de-escalation, security, code grays, cease offending drugs such as antidepressants, because as we know, antidepressants can send you into mania if you have bipolar affective disorder, and also sedation if that's required. So benzos, antipsychotics, whether that be oral, IV, or IM, for acute behavioral disturbances. Next, you want to get a history. If this isn't possible, a collateral history, do a mental state exam, a risk assessment, and also just a physical exam. You want to do OBS and vital signs, the investigations we talked about earlier, and then supportive management such as IV fluids. Most of the time, if it's a manic presentation, you may want to admit them as well. So whether that be voluntary or involuntarily on an assessment order or a treatment order, and then you'll get a psych review and the inpatient team will take it from there. In terms of subacute management for bipolar disorder, in terms of lifestyle changes, cessation of substances or offending medications, and you can refer them to relevant drug and alcohol services as well. SNAP-W, sleep hygiene, giving a structured daily routine is seen to be quite helpful as well, and also delaying individuals from making their own decisions for a while. Not sure how long. I think it's a case by case thing, but yeah, it's a good intervention. In terms of biological management, so lithium is the first line for classical euphoric grandiose mania, which is the one that I've been talking about for the past however many minutes. And the big one to know about lithium is that it's very nephrotoxic and thyrotoxic. So getting a baseline kidney function and thyroid function would be important if you're starting them on lithium. If not, you can use anti-epileptics such as sodium valproate, lamotrigine, and carbamazepine. A lot of these are also teratogenic as well, so you can keep that in mind. And there are different indications that I think will be covered in the pharmacology lecture. For example, lamotrigine is used in more depressive kind of course of disease for bipolar disorder. You can also use antipsychotics for psychotic features of bipolar. So that's aripiprazole, quetiapine, risperidone, or olanzapine. And severe cases, you can also use ECT as an intervention. In terms of psychological therapy, you can use adjunctive psychotherapy. So there's no real evidence for the benefit in acute mania, but yeah, CBT, IPSRT, and family-focused therapy you can use that subacutely. Psychoeducation, so safety netting, informing the patient about what the actual condition is and how to recognize the red flags, a crisis management plan, and outpatient mental health and GP follow-ups. In terms of social management is quite a big thing in psych. I don't know how relevant it will be in terms of passing your exams, but once you're on the ward, you'll see that most of the management is trying to get patients with appropriate housing, occupation, that kind of thing, academic attainment. You can also use support groups or family support, community involvement, and also social workers and case managers. So bipolar 2. Oh, sorry, just to, I don't know if I added it to the slides, but bipolar 1 definitely is diagnosed with mania, but not necessarily major depressive disorder. I think that's on the next slide. But bipolar 2 is a mood disorder characterized by at least one major depressive episode and at least one hypomanic episode. So the depressive episode should last at least 2 weeks, and hypomanic should last at least 4 days. Females are more affected by males, and the age of onset is late 20s. So according to the DSM criteria, hypomania is defined as an elevated or irritable mood with increased activity or energy for at least 4 days, very similar to mania. Dig fast symptoms, so that's also the same. But the difference is it's no social or occupational impairment, never hospitalized, and no psychotic features. So if they have any form of psychosis, um, it's not hypomania, it's mania. And also hospitalization, like the fact that if they've ever been hospitalized because of this, then it's also mania. Um, so yeah, the other ones are they've definitely had some kind of change in function, and mood disturbances and functional change is observable by others, and it's not due to substances. So the bipolar 2 DSM is at least one hypomaniac, one major depressive, never had a manic episode, and not better explained by a schizophrenic spectrum disorder. And alternation between depression or hypomania causes clinically significant distress or impairment in important functional domains. And the management investigations are usually the same as BPAD, although I think it would be a little less like on top of it in terms of medication management. Um, so type 1 versus type 2. So the definition, yeah, here it is. So type 1 is a manic episode plus or minus depressive episode, and type 2 needs to have a hypomanic episode and a depressive episode. Symptoms are the same. Length is at least 7 days for mania in type 1 and at least 4 days in type 2 for hypomania. Impairment in type 1 is severe with possible hospitalization, and impairment for type 2 is minor to none with no hospitalization. Psychosis is not possible in type 2, but definitely possible in type 1 and pretty common in type 1, I think. So next is drug-induced mania, which is an R3 condition. It's defined as an increased disinhibition or irritable mood, plus or minus depressive symptoms during and or after substance intoxication, withdrawal, or medication exposure. So if we want to talk about the causes, a big one is phencyclidine, which is an illicit stimulant drug. This may present firstly as delirium and then progress to the manic/mixed state. Other stimulant drugs can also induce manic symptoms, so they usually appear within minutes to hours of intoxication and resolve within 2 days. It's more of a brief episode. Medications that can do this are corticosteroids, because of course it's corticosteroids, and immunosuppressants are common medication causes as well. Manic symptoms usually begin several days after ingestion, and higher doses are more likely to cause bipolar symptoms. Could also consider it in alcohol, hallucinogens, sedatives, hypnotics, and cocaine, which is a stimulant as well, I believe. In terms of management, your way just ceasing the drug, considering weaning if you need to like minimize the withdrawal effects, and also consider the medical outcomes if you're ceasing a medication. Um, Patient education is important, and also psychosocial support if needed, and also drug and alcohol services, all that. If it's a heavy substance abuse disorder, you could also go down that route and refer to social work, mental health services, community case managers, that kind of thing. Cyclothymia. So the definition is a chronic fluctuating mood disturbance characterized by hypomanic and depressive symptoms that are chronologically apart. So then they can't be happening at the same time, which is sounds a bit impossible, being depressed and manic at the same time. The DSM criteria So periods with hypomanic symptoms and periods with depressive symptoms that don't meet the criteria for specific episodes for at least 2 years. So during the past 2 years, symptoms have been present for at least half the time, and symptom-free periods are no longer than 2 months. Um, Criteria for major depressive, manic, and hypomanic episode never met. And it's not better explained by any other condition, not substance related, clinically significant impairments in important areas of functioning. So yeah, it's quite a vague, I think, condition that it's like you don't really meet the criteria for anything, but you're still getting um disturbances to your life looking like cyclothymia. And it's quite chronic. You have to have it for at least 2 years. In terms of management, there's not really much evidence for treatment, so you can use stabilizer medication similar to the pharmacological approach to bipolar affective disorder. And you should also be careful with antidepressants in case they induce mania. Psychotherapy, so patient education and family group therapy can be used as well. So next is depressive disorders. Yeah, that wraps up bipolar disorders. So in terms of depressive disorders, um, this is like your normal functioning, and a major depressive disorder would include like very low mood. And then persistent depressive disorder is when your mood fluctuates, but it's like generally underneath the euthymic state. So you can see it's just like going up and down, but you're still kind of depressed. Not really severely depressed, but you know. And then substance induced is any depressive symptoms that are caused by substances. So if we want to have a look at the differential, so if we work down the psych pyramid, in terms of organic symptoms, you can have medical conditions such as hypothyroidism and also medications. Sorry, such as corticosteroids, beta blockers, and then psychotic disorders. So schizoaffective disorder, which is can cause very severe depression, and also a prodromal symptoms for schizophrenia. So this is the like months to a year before um the onset of an acute schizophrenic episode where they're kind of changing and functioning and you're not really sure why. So bipolar, so you can get depression in both of the bipolar disorders and cyclothymia. And in terms of just depressive um conditions, major depressive disorder, persistent depressive disorder, disruptive mood dysregulation disorder, which is a new one. And lots of personality disorders can also result in depression. So in terms of major depressive disorders, they're characterized by a persistently low mood, plus or minus anhedonia, which is just when you don't have any interest in the things that you used to be interested in. This is also associated with other neurocognitive symptoms and suicidality. The lifetime risk is about 15%, and females are twice as likely to be affected by males. The onset is around 25 to 30, and it's a gradual onset. So in terms of risk factors, females and family history are the big one. Um, and psychological, so acute stress event or trauma. MDD occurs most often in those with no close interpersonal relationships or those that have been recently divorced or separated. And also medical conditions can predispose you to depression. So obesity, cardiovascular disease, diabetes, they're all at an increased risk. The mnemonic that you can learn for the symptoms is M-SIGE-CAPS. And this is according to the DSM-5 criteria. So M is mood, so you'll have a low or depressed mood. Sleep, hypersomnia, or insomnia, both are signs of depression. Interest deficit, so that's anhedonia, feelings of guilt, worthlessness, and hopelessness, lower energy, so fatigue, problems with your concentration or indecisiveness, appetite increase or decrease, and this can lead to quick weight changes, and psychomotor agitation or retardation, and also suicidality. So whether that be thoughts, plans, or actions, like any of that kind. It's also important to note the difference between active and passive suicidal ideation. So suicidal ideation is when they have thought like, I don't want to be here, I like don't really want to wake up tomorrow. But if you have active suicidality, you're thinking of like, I'm going to do it on this day, by doing this, and they're actually thinking about it. And that can be an indicator for a more severe depression, and also will work into your risk assessment as well. They'll be at a much higher risk. So in terms of MSc findings, the appearance is poor self-care, signs of self-harm, changes in weight, behavior, psychomotor retardation, poor eye contact. In terms of engagement, they're guarded, they're monotonous when they speak, and the emotion is dysphoric or flat or a depressed mood. You can have psychotic depression with evidence of catatonia and also nihilistic delusions as well. And thoughts are slowed, depressive themes, Cotard syndrome. Okay. And in terms of the DSM-5, so you need to have at least five of the nine MSIGE-CAP symptoms within the same 2-week period, and at least one of them are low mood or anhedonia. Um, So the second criteria is clinically significant distress or impairment, as most of them do, and not attributable to a medical condition or substances, not better explained by any schizophrenia spectrum disorders, and you've never had mania or hypomania. So in terms of management, lifestyle management includes SNAP-W, cessation of substances that contribute to low mood, so corticosteroids, benzos, hormonal contraception, and also improving your sleep hygiene. Social is similar to bipolar, so housing, occupation, and academic attainment. Support groups, family support, community involvement, and social worker or case managers. Psychological therapy is quite important as well. So CBT and IPT, cognitive behavioral therapy and interpersonal therapy. This should be offered in first line in patients with mild depressive episodes. Um, and also other things you can use are acceptance and commitment treatment and mindfulness cognitive treatment as well, and a crisis management plan. In terms of biologics, a biological treatment, you can use antidepressants first line in severe depression. Sorry. So SSRIs, SNRIs, NASSA, NRDIs, and NARIs. Second lines will be tricyclic antidepressants and MAUIs. And you can also augment them with lithium plus or minus antipsychotics. So you can combine antidepressants and try transmagnetic. I don't remember the exact name for this. After you've if you fail two medication trials. So what it is, it's like they use a metal coil and they stimulate your brain. I think it's like it sounds similar to ECT with me. I've never seen it before. I just um saw this in my reading. But in severe depression, you can also use ECT. So the management approach is that psychotherapy should be offered first where appropriate, and medication for more severe cases. Dual medication and psychotherapy wields good results, and medication monotherapy recovery rates only approximately 30%. So I think the bottom line is that psychotherapy is quite important in patients with depression. In terms of which specific antidepressants to use, I think that'll be covered in more detail in the pharmacology lecture. But it's usually SSRIs first. So a good topic to have a good like understanding of is the depression versus grief. So in grief, feelings usually come in waves, often intermixed with positive memories of the deceased, or and in depression, mood and ideation are almost constantly negative. So I think the real like issue with this is that people may over medicalize grief and diagnose it as depression and treat something that shouldn't be treated. And grief is like a normal human process. And so obviously you don't want to like give them medications if they don't need medications, but at what point do you need to medicalize it because they aren't functioning anymore? Um, so another way to distinguish them is that in grief, self-esteem is usually preserved, whereas major depressive disorder, corrosive feelings of worthlessness and self-loathing are more common. It's often thought that MDD should not be diagnosed in the context of a acute group because, yeah, that's what we're talking about. And so the bereavement exclusion was something that the DSM before had, which advised not to diagnose major depressive disorder in the first 2 months post loss, it's now been removed, and they've been advised that diagnosis can be based on clinical reasoning. So I think the point is that you can now diagnose major depressive disorder whenever based on the functional impairment. But this does come up in exam questions a little bit, and I have a one to show you a little bit later on. So in terms of affect, the grief affect is emptiness and loss, whereas major depressive disorder, it's persistently low mood or anhedonia. The course, it decreases intensity over days to weeks and occurs in waves for grief, and it's persistently low for MDD without any intervention. And yeah, self-esteem is preserved in grief and not in depressive disorder. Let's talk about the major depressive disorder subtypes now. So there's a lot, and they're not super high yield, but they do come up a little bit. So firstly, atypical depression. So it's a subtype of depression characterized by mood that is highly reactive to environmental circumstances. This is associated with conduct disorder, social phobia, interpersonal dependency, or low self-esteem. And you can use the Rails mnemonic to remember the signs. So R for reactivity and mood, appetite increase, interpersonal rejection sensitivity, leaden paralysis, and sleep increase. So the management is that this has a poor response to tricyclics and ECT, but a great response to MAOIs. And usually with these MDD subtypes, it's like you'll be diagnosed with major depressive disorder, and then if you meet the criteria for these subtypes, you'll have plus atypical features. That's how they come about. So pediatric depression, this is low mood in children and youth. So management, lifestyle strategies to promote physical health, dietary patterns, and sleep. This should be first line in treatment along with psychotherapy, not medications. So poor lifestyle are associated with increased depressive symptoms in adolescents, and usually use CBT for the preferred psychotherapy. Pharmacological should never be offered first line in adolescents, and if you need it, it's fluoxetine, which is an SSRI with a half-life of about a week. And this is because, as we know, SSRIs, they have that 6-week period in which you need to take it every day to reach the therapeutic window. But I think the idea is that in youths, they're a little bit less compliant with medications. Whether or not that's true, I'm not sure. But there's less of a consequence if you were to miss a dose of fluoxetine because it has a longer half-life. Um, and yeah, there's a high risk of suicidality in children because for the 6-week window after starting an SSRI, you do get an amplification of the negative symptoms of depression. So yeah. Melancholic depression. So this is characterized by loss of pleasure and prominent physical symptoms. There's a high genetic link to this with males being more affected than females, and there's a high risk of progressing to psychotic depression, so developing like catatonia. The clinical signs, according to the DSM, so you need one of the following: loss of pleasure in activity, so anhedonia, or lack of reactivity to usual pleasurable stimuli. And also 3 or more of the following, so a depressed or empty mood. Depression is worse in the morning, early morning wakening, at least 2 hours before the usual waking time, psychomotor agitation or retardation, or significant weight loss or anorexia, as well as excessive guilt. So in terms of geriatric depression, that is depression in adults occurring age 16 over. According to the DSM, it's similar symptoms to traditional major depressive disorder, but more common to report anhedonia as opposed to like low mood, and also reporting cognitive symptoms and somatic complaints as well. To diagnose, you can use the geriatric depression scale, which is like a questionnaire. And you should keep in mind the differentials of delirium and dementia because they all can present as each other, which gets really confusing. In terms of an organic screening, you want to do a full blood count, electrolytes, TSH, and B12. So B12 is a very good like baseline test to do because it can cause depression in the elderly. In terms of management, first line is cognitive behavioral or interpersonal therapy, and pharmacology, SSRIs, SNRIs, and mirtazapine. So mirtazapine specifically, from the way I remember it, is a good one for older people because it's good for increasing sleep and appetite. So if you have a very like frail, skinny, older person who is not getting very good sleep, benzodiazepine's the way to go. And you can also use ECT if it's real bad. Post-stroke depression, so developing depression after a stroke. There's a high risk acutely, and it's common to develop depression within 1 year. But yeah, keep a lookout for the couple like weeks. I'm not sure if there's a physiological link, but if you were to develop a stroke and go through all the rehab and everything, I think it's quite common to develop depression. In terms of management, so SSRIs like escitalopram, fluoxetine, and sertraline, as well as psychotherapy, so CBT and IBT. The management is not very different to how you would manage a traditional depression. Um, Yep. And postpartum depression. So this is the development of depression during pregnancy or within 4 weeks of delivery. 15% prevalence in adult women, and women with postpartum depression are at a higher risk of recurrence. In terms of diagnosis, it's the same diagnostic criteria as MDD, plus it's within 4 weeks of delivery or during pregnancy. You can use the Edinburgh postnatal depression scale to also diagnose this, and some differentials include baby blues, iron deficiency, hypothyroidism, anxiety disorders, and OCD. So psychotherapy is first line for mild to moderate postpartum depression, CBT and IPT again. Pharmacology is first line in severe postpartum depression. So you want to use an SSRI such as escitalopram, or sertraline. Um, from what I remember, sertraline is the safest for pregnancy, S for safe. So maybe sertraline first, and then also ECT for after pharmacological management has failed. Social management, structured exercise, and bright light therapy has good evidence. And so we have psychotic depression now. So that's major depressive disorder plus psychosis, whether that be delusions or hallucinations. And treatment is usually managing the underlying mood disorder, which usually resolves the psychosis. Dual therapy is great for that. So antidepressant plus antipsychotic. And then the next one is perimenopausal depression. So that's a subtype of depression experienced by people going through the perimenopausal period. Management will be CBT and desvenlafaxine, which can help with perimenopausal symptoms. Yeah, so seasonal affective disorder, also known as SAD, is a subtype of major depressive disorder with mood changes related to seasonal changes. The common cause for this is depression in winter and then remission in spring. In terms of the diagnosis, the essential one is one type of mood episode must follow a seasonal pattern. So depression or hypomania or mania has to happen at the same time every year. Um, there's a regular temporal relationship between mood and seasons. Remissions also occur at usual times during the year, and it's happened for at least the past 2 years. Seasonal episodes outnumber non-seasonal episodes during a lifetime. And in terms of management, first line is bright light therapy. So the usual one is 10,000 lux, which is light intensity, I think, for 30 minutes in the early morning for 6 weeks. And you can also use bupropion. Bupro, I can never pronounce it. Bupropion. And this can prevent SAD if you start the treatment before winter. So it's more of a preventative rather than a acute treatment. So substance-induced depression, that's the development of depression whilst intoxicated or withdrawing from certain substances such as alcohol, illicit substances, or prescribed meds. Some high risks are antivirals, beta blockers, antidepressants, anticonvulsants, triptans, antipsychotics, and hormonal agents such as tamoxifen, oral contraceptives, and corticosteroids. According to the DSM, it's prominent and persistent mood disturbance, so low mood or anhedonia. The clinical picture can correlate symptoms with a specific substance and evidence that substance can cause mood disturbance. So this is usually done through a history. And yeah, it has to be one that like has evidence to cause a mood disturbance. It's not better explained by any other mood disorder, doesn't occur exclusively during delirium. So if you can only diagnose it during delirium and once it's out of delirium, it's fine. It's not substance-induced depression and clinically significant disturbance to daily function. In terms of management, you cease the substance, manage withdrawals appropriately, and then referral to drugs and alcohol services as well as patient and inpatient rehab as necessary. So, persistent depressive disorder. This is a mood disorder characterized by a depressed mood for most of the day, for more days than not, for at least 2 years, or 1 year if you're a child or adolescent. So, this is more of a chronic depression and it's less likely to resolve than so it's less likely to resolve than MDD, and its early parental separation is a big risk factor for an adolescent diagnosis. In terms of the DSM, so it's a depressed mood for most of the day, for more days than not, for at least 2 years, and the he's too sad mnemonic. So you need to have at least two of these symptoms: hopelessness, low energy, low self-esteem, happened for 2 years, sleep is decreased, appetite is decreased, and there's difficulty making decisions. So the management principles are similar to that of major depressive disorder. Um, and medication treatment or dual therapy with psychotherapy is preferred over medication monotherapy in persistent depressive disorder. Disruptive mood dysregulation disorder. So this is a relatively new diagnosis for children with chronic and severe irritability and severe anger outbursts. There's a strong link to comorbid psychiatric diagnoses. So it's commonly oppositional defiant disorder. Um, Signs and symptoms. So severe recurrent temper outbursts that are disproportionate in intensity or duration to the situation. So they can have verbal outbursts or like physical aggression, outbursts inconsistent with developmental age, and it occurs 3 or more times a week on average. Age of onset of primary symptoms has to be before age of 10, and the diagnosis can only be made for those aged between 6 and 18. There's no evidence for pharmacological management just yet, only support for emotional regulation through parents, schools, or therapists. So yeah, that's all. I'm going to cover some exam questions now, but these are from some recent past exams. So if you want to do those on your own first, maybe come back to this later, but we'll work through some questions. So the first one, 30-year-old male is brought to your clinic by his mother. He's wearing all black and appears sullen. His mother tells you that his father passed away over 2 years ago. She's remarried and is trying to move on with her life, but he appears to be stuck in his grief. He also admits to hearing the voice of his deceased father, and the voice says, "You're a bad son. Punish yourself and join me." What's the most likely diagnosis? You can pause if you'd like. I'm gonna move on. So the answer is major depressive disorder. So this is one of those grief versus MDD questions. Um, and some of the reasonings that I thought of is the timeline. So it's been 2 years since his father has passed, and the bereavement exclusion was like 2 months or something. So it's quite a significant um time. There's psychotic features, so this isn't usually seen in subacute grief. He's hearing voices and they're quite like the self-esteem aspect is low. You're a bad son, punish yourself and join me. Although there is evidence that um there's hallucinations in acute grief where they'll want to go and join the dead, but that's usually for a positive reason. This is like a negative, low self-esteem kind of reason. So more consistent with major depressive disorder. The next question, a 72-year-old woman with a long history of BPAD presents to the ED. On a review, she is speaking so quickly that the doctor struggles to understand her. When the doctor tries to ask her to slow it down, she replies, "Don't interrupt me," and continues talking. What best describes the patient's primary feature? Again, you can pause. I'm just going to move on. So it's pressured speech. She's got bipolar affective disorder. So this could be a manic disorder. And yeah, you're unable to interrupt her, which is consistent with the flight of ideas and pressured speech. So yeah, it's pressured speech. The next question, a 45-year-old recently separated man admitted to hospital presenting with persecutory delusions, derogatory auditory hallucinations with low mood, anhedonia, increased anxiety, poor sleep, poor oral intake, and acute ideation. What's the next appropriate management? So this is severe psychotic depression. You can see this because he's got the psychotic features, so persecutory delusions, auditory hallucinations. He's also got an acute risk to his own life, with poor oral intake, suicidal ideation, everything like that. And if you think about it, if you were to start an SSRI right now, it really wouldn't do much for him. Um, because it takes 6 weeks to reach the therapeutic window anyway, a 6 week inpatient admission to see how it goes might not be the best thing. So you firstly need to manage his psychosis and suicidality, and ECT would be the best way to do that. School teacher has been on a regular dose of an SSRI depressant for the past few months. Despite a gradual reduction of her depressive symptoms, she continues to have negative beliefs, and these are affecting her performance at school. Again, you can pause if you'd like. And yeah, the question is, what's the next appropriate management? So CBT, first line depression management, is pharmacology or psychotherapy, dual therapy. Um, so that's either CBT or IPT. IPT isn't on here, and CBT is usually the go-to anyway, so that would be the answer for this. She doesn't need an admission to hospital. Amitriptyline would be inappropriate antidepressant to give at the moment. She's not really in crisis, no need for electroconvulsive therapy. Escitalopram, maybe if you think that the SSRI isn't working, you could try a different one. And these are all other psychotherapies, but yeah, CBT would be the first one you would want to try. And definitely not mirtazapine or venlafaxine yet. A 14-year-old with a 6-week history of lowered mood, loss of interest in usual activities, sleep disturbance, difficulty concentrating, loss of appetite and energy, but no weight loss, suicidal ideation or guilt. What's the most appropriate treatment? So fluoxetine. She's a young person with depression, so she gets fluoxetine. And there's no option for psychotherapy here, so I'm assuming they just wanted you to choose a medication for her. 28-year-old woman reviewed at clinic. Her parents have complained that over the past 2 weeks she's not slept and has been out binge drinking over the weekend. Reports from her friends is that she's spent excessively at the bar and is making claims that she's a CEO of a company that she recently joined as a receptionist. Prior to this weekend, her behavior has been unremarkable. What's the most likely diagnosis? So again, you can pause if you'd like. She's having a manic episode, so there's an acute change in behavior. And if we're going down dig fast, she's got her decreased need for sleep, impulsivity, grandiosity. She's psychotic, so it's not hypomanic. It's not enough for a BPAD diagnosis, and BPAD isn't even on here. But yeah, manic episode would be the most appropriate diagnosis at this point. No episode of alcohol use disorder, brief psychotic disorder. Um, could be, but she has symptoms of decreased need for sleep, and also, um, yeah, it's more like manic episode vibes. Cannabis use, cyclothymic. It's not chronic enough for me to be cyclothymic. Not really GAD. Not hypomanic because she's psychotic. She's not exhibiting depressed mood, and there's no evidence for PTSD or schizophrenia. So yeah, manic episode would be the most likely one. The next one is a 69-year-old former engineer with a 4-year history of social withdrawal and decreased interest in formerly enjoyable activities, associated with increased questioning of the point of life at his age, as he feels that he's already well into an inevitable decline. This is in the absence of altered sleep, significant weight gain, or active thoughts of suicide. MMSE is 28 and short-term recall is 3 out of 3. Again, you can pause. I'm gonna go. And the diagnosis is persistent depressive disorder. So because his MSE is 20 out of 30, it's not a neurocognitive disorder or dementia. Um, because he's got anhedonia, we know it's a depressive disorder, and he's been experiencing this for 4 years. So it's not typical of a depressive episode, re-MDD, but it's more of a chronic course, which is indicative of persistent depressive disorder. Yeah. The next one is a recently widowed 71-year-old woman presents to her GP saying that she's unable to go on and sees no reason to live since her husband died suddenly 3 weeks ago. Of course, I'll not do anything impulsive, she says, and she eats because she knows that she should, but is not losing weight and continues to enjoy babysitting her children. What's the most appropriate management step? Gonna go now. So grief counseling. So her husband died 3 weeks ago, which is within the so these exams were written a couple years ago before the bereavement exclusion was cut out. I think. I think. Don't quote me on this. Um, but I think the principles are still the same. And so suddenly died 3 weeks ago. It's very normal for her to be depressed. And so you wouldn't start any extreme medications or that kind of thing, maybe some CBT, but grief counseling is the most appropriate. Um, Also with grief versus MDD, you have the preservation of self-esteem. So she eats because she knows that she should, and she's still enjoying babysitting her grandchildren. So it's not a persistent mood disorder, it's more of a wavy thing from what I'm seeing in this question. So yeah, grief counseling. And I think this is the last question I have, but a 65-year-old woman presents because she's concerned she's developing dementia. She says she is becoming more and more forgetful and is not sleeping or eating adequately. She can't provide some history or complete cognitive testing, answering I don't know to multiple questions. You can pause. I'm going to move on now. So geriatric depression often manifests with cognitive impairment. So the diagnosis here is major depressive disorder. Um, I don't really know with this question whether why you would completely rule out um a dementia. I guess dementia isn't a option here, or Alzheimer's is. Um, but yeah, I think the takeaway is that cognitive impairment is usually depression in old people. Yeah. So I think that's the end of my lecture. Thank you very much for listening. If you have any more questions for me, you can definitely email me. Um, and yeah, good luck studying with exams and everything.